My name is Dr Supriya Chowdhury. I'm an anaesthetist and pain medicine specialist working in Sydney, Australia. I work across the space of acute pain management, subacute or transitional pain and chronic pain, and still practice anaesthesia and pain medicine. I'm here with Professor Lesley Colvin, who's come all the way from Dundee. She is a professor in pain medicine and the Associate Dean for Research at the University of Dundee. And we've had the opportunity to have you here as our keynote speaker, enlightening us about adverse childhood experiences and chronic pain. Maybe if you could just tell me a little bit more about your research.
Yeah, sure. So I'm Professor of Pain Medicine, but I also work clinically as a consultant in the pain service in Dundee. And one of my interests there for a long time has been pain and addiction. Many of the people that I see in that clinic give a history of significant adverse childhood experiences of trauma during childhood, which is where I first became really interested as to why I was seeing so many of those in that clinic, and then actually in other patients in the more general clinic. So I'm part of a consortium that is led from Dundee. It's led by my good colleague, Professor Tim Hales, and it's called the CAPE Consortium, the Consortium Against Pain Inequality, focusing very much on understanding the impact of adverse childhood experiences on chronic pain and also the response to treatment for chronic pain.
So Lesley, how can we improve or integrate into our practice how we approach patients who've had adverse childhood experiences, and particularly how do we discuss this? As part of my practice, I do try to ask patients if they have suffered any particular traumas or neglect or emotional neglect, but I'm not sure I do it well. And often patients say, I don't want to talk about it, and then I'm not really sure where to take it further.
Yeah. I think the fact that you're asking about it at all is that you're doing it well. It was interesting in the session this morning that the majority of people in the audience do ask about adverse childhood experiences, where from speaking to other healthcare professionals, particularly GPs and primary care, but also neurologists, it's not something that they actually even ask about. From the discussions that we've had with patient partners, the people with lived experience of chronic pain and adverse childhood experience, they want to be asked in general. And often go for many years before someone actually asks them about it, or indeed they feel able to disclose to someone. And we know that said this morning that the average age in women of disclosing is between the ages of 40 to 50, at which time the long-term impact is already there. So we're dealing with a problem that's already established rather than trying to prevent problems occurring.
I think you mentioned in your talk as well, as part of some of the studies that you've done, patients who have sort of comorbid mental health conditions and the link with adverse childhood experiences. And so I was wondering, given that there's also obviously a link between mental health comorbidity and chronic pain, whether the same types of pharmacological therapies, so things like, for example, SSRIs, SNRIs, general mood stabilizing agents might be helpful for our population.
Yes, potentially. I mean, I think one of the important things is with adverse childhood experiences and chronic pain is that the risk is increased, and the risk of depression or mental health illness is also increased. But it's not just mental health, it's also physical health. And again, patients, that feeling of not being believed and everything just being put down to it's just because they're depressed. I think we need to move away from that and say actually there's a biological basis, a neurobiological basis as to why people may have comorbid chronic pain and depression and other illnesses, increased risk of cancer, diabetes, cardiovascular disease, substance use, a whole range of things.
You mentioned the CAPE screening questionnaire. Are you able to maybe tell us a little bit more about some of the questions that are asked as part of that?
Yeah, sure. So just taking a step back, when we started the project and we did a systematic review of what questionnaires are out there, there were 61 questionnaires, 11 of which were used fairly frequently. And we thought, well, why don't we just use one that's already been validated? And what we then did was we worked with our patient partners to assess all of those, see how robust the validation was, and importantly, what the patient partners thought of them in terms of did they ask the right questions, did they ask the right questions in the right way. And what was really clear was, in fact, that none of the questionnaires actually did what it said on the tin. So although we thought we had good questionnaires to understand adverse childhood experiences, in fact, when you talk to the population that are affected, the questions were not being asked in the right way. So that means that the data that you get is going to be skewed as a result. So that's what led us on to developing our own questionnaire. And we have used some of the concepts from the questionnaires that exist, the ones that were selected as being asked in an appropriate way, in a sensitive way. And we've pulled together, it's quite a long questionnaire, not so long that psychologists like it actually, psychologists like it, so it's not too long. But it covers quite a number of areas. So there's the kind of, childhood abuse, physical abuse, sexual abuse, emotional abuse, physical and emotional neglect, which are the kind of standard ones that are asked about. But then much broader ones relating to household dysfunction, community violence, which is particularly relevant in our current world climate and what the long-term effects of that will be. Loss of a parent, divorce, separation, so poverty, financial hardship, so a much broader range of factors that might impact and be classified as adverse childhood experiences. Now, one of the things is that not all of those, so for instance, separation of a parent may or may not be an adverse childhood experience dependent on the impact that it has on the child. So it's that something that undermines the child's sense of safety or causes distress, and trying to pull those together. So we're using the questions as a surrogate marker because we're asking about experiences but not the impact of the experiences. So we're using those questions as a surrogate marker of something that may impact long term.
And in my practice, in one of the clinics that I work at in Sydney, we have a large population from a culturally and linguistically diverse background. In particular, there's a large refugee population, people who have fled war-torn areas, victims of torture. I was wondering if the questionnaire is applicable or valid in these populations, and particularly if it's translatable.
So, at the moment, we are validating the questionnaire in the Scottish population. We've started doing a little bit of work with collaborators in Nepal. In fact, one of your colleagues, Saurabh Sharma, who is at Sydney, we're working with him to look at it in a completely different cultural environment. But certainly there's the potential as we move forward to work and collaborate more internationally. But at the moment, it's absolutely not validated in other populations, and it's something that we need to think about.
I was wondering, we've talked a lot about how to maybe identify these individuals. What can we do more in terms of treatment and then also primary prevention maybe?
Yeah. I mean, ideally, for any form of chronic pain, if we can look at prevention. So the earlier we ask about it, the more likely we are to be able to look at some trauma-informed care to try and correct some of the potential long-term consequences. And as pain specialists, that's hard because we don't see people early on in their patient journey. But that's where I think we've got a role in terms of education of other healthcare professionals, social professionals, even within education, to make them aware of the long-term impact of this so that it is flagged up as early as possible and, importantly, that there are services in place to deal with it. So it's also working with policymakers to make sure that the funding is in place so that we can deal with it when it's identified.
I have a question that's maybe a little bit beyond what we've been discussing so far, but I have done a little bit of reading on intrauterine trauma and the effect of sort of a traumatic birth from the mother's experience or else domestic violence or family violence. And I was wondering whether that's something that you might be able to talk to at all.
In terms of adverse childhood experience?
Yes. Yeah.
So, I mean, I think any form of if it's related to medical trauma, obviously during childhood, and again that was something that came through that is not often assessed as an adverse childhood experience, but children who have poor health and spend a lot of time in hospital getting various medical interventions or surgical interventions, often there are long-term consequences of that. And again, it was interesting, one of our patient partners, it wasn't intrauterine trauma, but she did have gynae conditions early on in her life, and she was really clear the impact that had had on her long term, both in terms of her chronic pain, but also much wider consequences as well.
Leslie, what advice would you give to practitioners or clinicians who aren't currently asking these difficult questions?
So I think the first thing, as you said, is although it's hard to ask about it. The other thing is to make sure that when you ask about it, you have some resources to hand that you're in a time-limited consultation, particularly if you're working in primary care, where you may not have a lot of time to deal with someone, but making sure that they can leave the consultation with some way of accessing support. And I did put up on the slide some of the New Zealand resources. We have resources back home. I think there are some in Australia as well. So making sure that you're not asking the question, triggering unpleasant memories, and then leaving the person with nowhere to go after they leave the consultation room. So you have to be prepared in advance and not just think, oh, I better ask about adverse childhood experiences, and all of a sudden you're in a situation that's actually quite difficult and you may have created harm. But I think it's absolutely important to ask about it in the first place, even if you yourself are uncomfortable with asking. But asking in an open way. The other thing is to use something like a questionnaire. If you're coming to the pain clinic and you're using a way of assessing things where they might be filling in other questionnaires, that you can include a questionnaire on adverse childhood experience, which includes links to support, so that they've had that in advance of coming to the clinic.
Thank you very much, Lesley, for sharing your research and your experiences with us. It's been a real honour to be able to interview you and hear you talk.
Well, thank you, and thank you for the opportunity of coming to talk to you and had some fascinating discussions.